Welcome for today's study session. And actually today we shall have a continuation of the topic on understanding growth. So in the past few days, we've learned about familial short stature, constitutional delay, growth delay. We've learned about Turner syndrome. And today we shall also have something still linked again to growth abnormality that we shall explore. As I still remember yesterday, there was a question that was asked about Turner syndrome, how the child can have or develop otitis. And then to that, we checked through again, and we noticed how, due to how the middle ear development in Turner syndrome children, how it is narrowed, the canal is narrowed, therefore it causes some fluid accumulation and later on leading to be prone to develop otitis media. So that was one of the major reasons for that. Now for today, for today's case that we shall have, it's our fourth case. It's about Bob, who is an 8-year-old boy who has always been shorter than his peers. His review of systems are negative. He has been generally healthy. His mother is 5 foot 4 inches. His father is 5 foot 9 inches. On physical exam, he has a cherubic appearance. His phallus is 4.5 centimeter. That is below the 10th percentile. And his upper to lower segment ratio is 1.0. His physical exam is otherwise unremarkable. So this is today's scenario or case. I would first like to know if there is anything that you don't understand, that you would like some clarity on before we get to solve it together.
What is cherubic appearance?
Okay, perfect. Let's actually have an image of this appearance and see here. So cherubic appearance. Okay. All right. So let's see, basically chubby, how they are all looking. Does it help us? So it's basically like a swelling of the posterior mandible. Yeah, I think with these pictures, at least, we are getting different part of it.
The fat tissue or the bone?
Repeat again.
I mean, enlargement of where mandible maxilla. It's a bone, right?
Yeah.
No, the fat tissue.
No, the bone actually is enlarged and therefore causing the face and swollen cheeks.
How possible?
Well, the genetic disorder.
Ah, I never see this one before.
well, I even see here for somebody who is having trapezism, but in this case, they are just telling us that he's having a trabec appearance. Yeah, just appearing.
Oh.
Yeah.
Okay.
Okay. Great then. All right. Any other question that what I would like more clarity on?
Upper to lower segment ratio. Is it upper limb to lower limb?
Yes, exactly. Yes, yes. From the pubic symphysis to the foot, there at the lower segment, and then upper goes above.
Phallus, is it Tanner stage?
Oh, okay. Yeah, good point. Good point. Well, it's actually related to the penis in terms of length.
Okay.
Yeah.
Okay. Probably.
All right. So, okay, this is basically the case. And before even further we try to solve it, let me again pinpoint some things that to remind us again in terms of conversion, like whenever we meet at 1 inch, so we can 2.5 in terms of centimeters, because it will be very handy. And you were asking about the phallus. Actually, they are for different age. Basically, we can have, for instance, we have our child, is Bob, is 8 years old, so it can fall in this range here. So it can go around 6 centimeters, like in terms of the phallus, in terms of length. But we have a specific graph that can also be of help. Also, that's like by age, the length, though the penile length here, it's maximal and it's in millimeter, but still we can easily convert. So in the case, they were telling us that it's falling below the 10th percentile, right? And his length was something 4.5 centimeter, if I remember well. So it would be around like 45 millimeter. It was 8. So if it's 8 and 40 is here, so the roughly 50 will be there. So it might be just falling. Sorry, it might be falling somewhere in this place here, and of which is still below the 10th percentile, like for the length actually of the penis. So yeah, so this is again another graph that we can be aware of, especially in the development of the kids. Something else that you were asking, it was about the upper to lower segment ratio. So as first, it reflects the trunk over the legs ratio. So the lower segment is basically the distance from the pubic symphysis to the floor level, and then the upper is just from the top, the pubic symphysis to the top. At birth, our upper to lower segment is the ratio. It's like the trunk, is sorry. It's like the trunk is longer than the legs. All right, usually like at birth. But then as we keep growing up, it starts decreasing. And it's decreasing like around 0.1 for every year until we get 10-year old. Until we get at 10-year, it's like now equal. So the upper segment and the lower segment becomes equal. But after 10-year-old, the ratio again kind of drops slightly, of which it goes below 1.3. But in specific diseases like Turner syndrome, what we learned yesterday, but there are also other diseases actually, like in rickets and achondroplasia. All of that, basically, the ratio will be like high and will be low in Marfan syndrome. So this is exactly something that we can all get to know. But the case of our child, he is 8 years old, and his ratio is just 1, so 1.0. So I think it's still actually quite okay for him. All right. So now, what should we do next?
Still like calculate the target height
Good.
and check the bone.
Good.
And then growth rate graph. Check the graph. And then genetic check.
Okay.
And blood test for hormone, growth hormone, everything.
Oh, okay, growth hormone. Okay. Sorry. Good point. I mean that you've actually pointed out. And for that, well, you've actually covered most of them, though there is really no need to have a specialized growth chart, especially due to what we are already thinking might be the issue. What do you think might likely be, can I say, the diagnosis?
Genetic disorder.
It might be certainly one of genetic disorders. Okay. Anything else that might still fall probably under differential diagnosis?
Still probably differential diagnosis, right? Differential diagnosis hypogonadism.
Okay, certainly something to think with the pituitary. Okay, I see.
Or hypothyroidism. And then familial sexual, short sexual.
Do you think we'll have? Oh, okay.
Delay.
Constitutional growth delay.
Yeah.
Basically, most of those diseases
Most
are
of them are soft or soft sexual. Yeah.
Okay, I see. Well, so in terms of our next step, for sure, we calculate the mid parental height. We still obtain the bone age and the laboratory screening tests. Basically, those actually will do with and will be of great potential help for what we need to find. So if we calculate the mid-parental height, I mean, since we've been trying to calculate it lately quite often, so it falls at 5 foot 9 inches. And then for the bone age, we basically just we basically just do a radiograph of the left wrist and hand. So I will not facilitate mainly in terms of calculation of the mid-parental height, since we've been trying it lately quite often. But I will try to go first forward and let's focus on those other thing. Now, for this particular child of Bob, so we have like his growth charter that was, though it's not really the, can I say, the specialized one, like for specific disease. Like last time we have a specialized one for Turner, right? Turner syndrome. And for this, but for him, it's not really a specialized one that we need to look for, but it's just the usual one that we usually use, like for stature, like height and weight and height. Like for instance, he's 8-year-old, but here is his growth pattern from birth to his age, to his current age. So we shall notice that as he kept growing, all this growth pattern basically turns to be way below the 3rd percentile, you know. And you remember in the case they were saying that he was known, I mean, he's basically known for, always known for being of short stature, right? So his growth pattern basically all was falling, you know, below the 3rd percentile, and currently is at 8 years old, and here is. And when it comes to the weight, at least he's you know, just right at the 50th percentile, like just usually other kids. So in terms of weight, there's not really much of big deal. All right. Now there is also another chart that he basically still we did for him. It's like later on in terms of follow-up, when as he has been growing up, you know, passing through, getting to puberty and everything, we shall notice that, okay, currently he's here, right, at 8 years old, but we shall notice as Bob keeps growing up, like into the follow-up and everything, as he's getting to puberty, you know, there has been at least a kind of rapid, you know, improvement, rapid growth. Because you remember, once children get in puberty, the growth rates kind of spikes, okay, spikes up, and we can even see already is already kind of spiking up, but still, I mean, by the time he got like 12, 13, somewhere there, but still was just falling like at the range of like the 3rd percentile, not really much up there. So this is just like a view of the before. Is 8-year-old, he was 8-year-old, and after what basically was still happening to his growth. Okay, now for today, when we talk about the laboratory screening, for this specific one, there are very important things that we'll need to pay attention to. You mentioned especially about the growth hormone, right?
Yeah, growth hormone.
Yes, good. Very important. You mentioned something very key, actually, about him. Why? First, it was important in terms of differential diagnosis, as you were mentioning, to rule out, you know, those disorders that can affect growth. We rule out the constitutional growth delay already through the family history. It can already help us, though he is not yet in puberty, I mean, for the time being, but already at least we can get to know about the parents and something like that. Something also very important, ruling out the growth hormone deficiency. Okay, for sure is likely to not fall into I mean, constitutional growth delay. What we learned already is a boy, nothing to do sorry, and his phenotypes nothing to do with Turner syndrome. Familial growth delay, familial growth short stature that we've learned already. But there's still other disorders affecting growth, all right? And among them already, it's important to rule, I mean, like in his case, for laboratory tests, it's important to rule out actually the growth hormone deficiency. How do we rule out? By basically by checking the levels, okay, of these specific parameters that we have here. And it's might actually not only be seen when there is a growth hormone deficiency, but even in malnutrition, hypothyroidism, renal failure, diabetes, all these actually factors, the growth factor, the insulin growth factor, one actually can be low, right? Also in this specific type of diseases. So nevertheless, it can already help us to pinpoint. And then we also have like a low level, of growth hormone that basically will also be deficient. So this is something that can, like a laboratory test, can also help when we are trying to monitor or to screen out a particular growth abnormality. So now we have a set of, can I say, conditions and diseases that can fall into our spectrum. Let's see which one already you can claim to be the most likely diagnosis.
Skeletal dysplasia.
Okay.
Chronic disease. A or E. Nocturnal, not growth hormone deficiency, not delay. So it's A or E.
Okay, A or E. All right. Good. So first, yes, I agree with you. This is ruled out. This is ruled out. Now, remember, in the case that we had, they kept saying how his physical examination and especially in terms of health, is unremarkable. He's healthy. Remember that? Oh, let me go back to the case. So they do not really present anything related to, yeah, here we go. So his review of system is negative. It means there is not really anything positive, that has been found out. Physical examination is also fine. So will we still really think that he's having a chronic disease? Because in case you would have a chronic disease, certainly the systems, when we will be doing the systems, there will be something that will actually be pinpointed. So with this check again, are you still thinking is most likely that diagnosis might be chronic disease?
Genetic disease is not chronic because it's long time. Long time it can call chronic, right? It's not acute.
Oh, it's in that manner that you were thinking, right?
Yeah. Because it's long term.
Yeah.
Long term is not acute. It's not medium, it's chronic, it's a long time forever. You cannot change.
Well, okay, thank you. I understand. Thanks for clarity on your train of thought. Nevertheless, there's still a big difference between chronic disease and genetic disease. As I think you've mentioned it yourself by pointing how when we talk about genetic disease, right? It's not that really you will treat specifically with the medication and immediately it gets eradicated by the good treatment of it. But when we are talking about chronic disease, certainly we are much more thinking of systemic diseases like cardiovascular diseases, pulmonary diseases, renal diseases that have been lasting. And that actually can be mediated by proper management. So here, certainly, we are not referring to a genetic one, but we are much more thinking of systemic disease. We'll learn soon in some of the upcoming cases. So now, if I clarify more, he's not there. I mean, it's not referring to rheumatic disease, but rather systemic diseases. Will it still stand as a most likely diagnosis? This one.
Likely diagnosed
Most likely.
for chronic?
Yeah. Will you still hold it?
Mm, chronic hypothyroidism? You mean that one?
Okay. I see. But he's not having hypothyroidism as well.
Chronic hereditary disease. Chronic gene disease. Chronic gene abnormality. Is it possible?
No, we'll not put the genetic one into falling into chronic disease. I'm just much more talking about systemic. So in short,
No, you
like
search it. Chronic disease, they can call chronic genetic.
repeat again.
Yeah, are genetic disease disorder chronic? Someone is asking. You search it, then you can find out the answer.
Sorry, I
Search
don't.
the page.
Sorry, I don't get to repeat again.
So you for example, you don't admit like genetic disease is chronic, right?
Yes.
But genetic disease also can be chronic. So you can search in the internet, then you got answer. Someone also asking questions like, are genetic disorders chronic? Then you got a lot of answers.
Oh, and among the answers, what have been found out?
Genetic disorders include certain types of birth defect,
Yeah.
and chronic disease, and then developmental problems, and then sensory defects are inherited from one or both parents.
Yeah. And for the chronic one, which ones they have I can say pointed?
Ah, okay.
Actually, it can be very an interesting topic to search out. So chronic genetic diseases, right?
Yeah. I'm waiting for website to open.
So I see they are saying genetic disorders, blah 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 blah. Okay. What chronic diseases are due to genetics? Oh, of course, I understand. When a disease, I mean, a disease is provoked due to genetics, so it's from that point that they are actually talking. Okay. So basically, it's like a genetic disorder causing a chronic disease, basically. So such as diabetes, heart disease. Yeah, it's I understand. It makes sense.
Oh, I open the website, and then chronic disease are bleeding disorder, childhood cancer, kidney UTI, and also slow growth, short stature, cystic fibrosis, sickle cell disease. All of them are
Yes.
genetic disorders. Which one is the one type? is chronic disease.
Yes, basically the genetic disorder causes that chronic disease, right?
One category.
Yes, I get.
They have 1, 2, 3, 4 category.
Yeah, I get the point of view. I get actually the point of view, of which I even see diabetes and all the others. I get the point of view. All right, so then where were we? Here on our specific. Okay, so we're still coming back on Bob. All right. And Bob, currently, with the information that we have about his case, is not having any systemic disease. He's not having as well any, I mean, his physical examination is actually all as well unremarkable. So in terms of chronic disease, the same, we will not also hold it. I mean, take it up. But now you pointed something about the skeletal dysplasia, right? You mentioned about skeletal dysplasia.
Yeah.
Yeah, you mentioned about skeletal dysplasia. But let's find out all the, okay, let's find out skeletal dysplasia. Okay, let's find out together if you still stand again for it. So we get all the points that are all right, that will basically fall into like under it. So we can use, all right, schedule dysplasia. Here we go. And see, right. Let's see if Bob falls in any of well, it's taking long. All right, here we go. So then, one thing about skeletal dysplasia, so it's first diagnosed by ultrasound before birth, and severe types actually may be fatal. All right. So now, one thing that we need to know, it's like there will be abnormal growth in the spine, in the skull, and in terms of bones, okay? Like the long bones, the arms, all of that basically can result in the short stature. All right. What are all the symptoms that we can have, especially in terms when somebody is having skeletal dysplasia? So, cervical spine instability, kyphosis is how the pattern of the spine will go. Spinal stenosis, we have the clubfoot, stiff joints. All right. So, in things that Bob is falling into currently, I see short stature. That's probably one thing. Large head with prominent forehead, long trunk, shorter arms. His ratio from the upper trunk and lower trunk was just 1, right? So currently it's not here. Hearing loss, vision problems, cervical medullary compression, and yeah, hydrocephalus, all of this. So based on all these symptoms that they have pointed out about skeletal dysplasia, do you still think Bob would most likely fall into this diagnosis?
Why not?
Why would you still think so based on the the case that they have offered us?
Or this, or which one? This is only option, right?
Okay, because there is something else actually into the options that is still most likely.
You see 5 options and the others are not possible. This is only possible.
Are you sure? Check back again. Check back. There is something there.
There is something else?
Check back again. Check again carefully.
Carefully. The most likely diagnosed skeletal constitutional growth hormone Turner. It's not Turner. It's not.
Yes.
Is it growth
It's
hormone
not.
deficiency? Chronic?
Yeah.
So you mean it's growth hormone deficiency?
Why not? Why don't you think that it might be?
Because but it is bone, his skeletal is enlarged by bigger than normal, right? You extremely point out his skeletal, his face is enlarged than normal.
Yeah.
So you point out that it's possible for some abnormality about bone, right?
Okay, understand your points. Understand your points.
Then if it is not, why you point out that?
Okay, that's good then. So let's
confuse someone.
Let's see now actually about this. So first of all, you're right. Okay, what is sure, we are not following any of this, but today let's learn actually about the hormone deficiency, actually the specific characteristic. Okay, and it will be very helpful for us to understand. All right, so something about the growth hormone deficiency, okay, or inadequacy. First of all, it's due to like a malformation or a damage of the hypothalamus or pituitary gland. And something else that we can also know about it, it can be combined as well with the pituitary deficiencies. So when all the other causes of short stature are ruled out, and now, I mean, it's important basically. It means the child will not have other causes of short stature. And now, in case there is a growth hormone deficiency that is present at birth, this, like in the long run, will also cause other things, such as what? Hypoglycemia, seizures, hyperbilirubinemia, and micropenis in males. All right. Do you still remember what was again the phallus of the child?
12.5.
Yes, exactly. It was below the 10th percentile, right? All right. So it like here first it starts. I mean, these are some characteristics that can start already helping us, like micropenis.
Is it because of the growth hormone? That was sex hormone.
I mean, like actually growth hormone as well can affect. I mean, this is something that is also very key about it.
Oh, really?
Yes.
Oh, okay.
And then also something else, the birth, and we are not sure actually about his birth weight and this, but it's a point for us that's to know that the birth weight and growth during infancy are often normal. Now, after 3 years of age, right, here starts again a subnormal growth rate. Usually it will be less than 2 inches per year, like in terms of growth rate, but most of mostly we saw his charts, right? You remember we saw his charts, like how as he kept growing up, from 1 year to 8th year, he was always below the 3rd percentile. So his growth rate was subnormal. Apart from that, also, yeah, we already know, yeah, the height is still actually at a lower percentile. Even after 8 years old, when he was going to puberty, still again, it was like at a lower percentile. Now, the weight increases with chronological age. You remember on the graph how his weight was just following normal with it was at the 50th percentile with the normal average. I don't know if you remember that. Okay, exactly, good. And then there is also a delayed born age. Unfortunately, we did not get details on that. So first, something that can help us, things that we can learn about this growth hormone deficiency. If it's present at birth, it also has some other comorbidities, such as hypoglycemia, seizures, but these ones will not have it. And especially when it comes to male, it affects even the length of their penis, that it becomes micro and so on. And then also as the child is growing up, especially after 3 years old, usually the growth is kind of slow and it follows a certain pace. But for them who have growth hormone deficiency, they will often and usually be below they will have a subnormal growth rate. And other thing also, their weight will go together with the chronological age. But when it comes to height, they will always fall off in progressively. So these are some key points, that we can add in our package of knowledge when it comes to growth hormone deficiency. But of course, the lab tests of the growth hormone and will also help us into that. So now, let me try to give us a spectrum of diseases that affect short stature, because most of them, some of them, or can I say most of them, are also organic related. For instance, one of big things, malnutrition. All right. This is like it's usually can always fall among differential diagnosis. So malnutrition can often easily leads to short stature. Apart from that, there are some renal diseases that can also cause like growth failure. We also have diabetes. That can also be actually something actually that can also lead to significant growth failure or retardation. We have some cardiac diseases, hematologic diseases, basically chronic anemia. When we have chronic anemia, it can be actually like something actually that even can affect. Apart from that, we have the gastrointestinal disorders. I think you were pointing that, right? When you were talking about the genetic disease leading to, to chronic diseases, like, for example, celiac disease, chronic liver disease, inflammatory bowel disease, whatever causing malabsorption. So all of these are things also that can also affect the stature of the child, the kids as they're growing up. Respiratory diseases, cystic fibrosis, asthma. Well, not much more even relate with asthma. It's now another additional knowledge. Endocrine disorders such as hypothyroidism. Okay, today we have talked about growth hormone, deficiency. It can also actually lead to short stature. Cortisol excess. Congenital disorders such as intrauterine growth retardation, skeletal dysplasia. Soon, I think in upcoming cases, we will also have one falling under skeletal dysplasia, and other genetic syndromes such as Turner syndrome. that we learned yesterday. So this is basically like a spectrum of different diseases that can easily cause short stature. So most of times, as we are passing through different cases, we'll be learning characteristics of some of them in such a way that whenever we meet a specific situation, it can be something that we can easily relate to because we have passed through a particular case.